Hello. Can you see me now? I can see my slides here. Yeah, yeah. Okay. So shall I start? Yes, 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 yes.
Are you ready?
Hello.
Yes, sir. Are you ready?
Hello.
Yes, sir. Are you ready?
Yeah, yeah.
Can I start the session?
Yeah, sure.
Okay. 3, 2, 1. Sir, you are live now. Over to you, sir.
Yeah. How can I enlarge my slides? Can I enlarge them? Hello. Hello. Yeah. Shall I start? Shall I start now?
Sir, yes, sir. You are live now. Over to you, sir.
Okay. Sorry for a little delay for today's session as I was busy in a case. So today we are going to discuss about managing the atherogenic triad and what is its Indian perspective. Next slide, please. So as we all know that atherogenic dyslipidemia is very common Indian scenario. I will be discussing my talk over headlines, these mentioned headlines like what is atherogenic dyslipidemic Indian scenario, and how does do we assess uh, atherosclerotic cardiovascular disease risk in Indian patients? What are the current recommendations for the treatment of these kind of patients, and what are the benefits of rosuvastatin in these kinds of atherogenic lipid profiles? As we all know that atherogenic dyslipidemia consists basically of three type of abnormalities in the lipid parameters of a high risk person. It is like a high level of triglycerides, elevated level of small dense LDL particles, and low level of HDL cholesterol. This atherogenic profile is a very high risk for atherosclerotic burden over all of the vascular system, and if not controlled timely can lead to various vascular events. So large, what is diabetic dyslipidemia, what is also known as dyslipidemia in the diabetic scenario, where a large TG rich elevated levels are there. This elevated levels of very low density lipoproteins and also elevated levels of apolipoprotein B with reduced level of small high density lipoproteins. This trio plays a very critical role in atherogenesis, and in the following slides we'll see how this trio affects in the pathogenesis and escalates the process of atheroma formation. As we can see in this slide that various pathophysiology of atherogenic dyslipidemia. As we can see here, a small dense low density lipoprotein causes increased infiltration into the arterial wall of the LDL, which is a lipid which helps in formation of lipid rich plaque. It also increases retention in the extracellular matrix. It has increased susceptibility to oxidation. It also increases the uptake of macrophages from the endothelium, and it has decreased affinity for receptors for LDL, which help in the clearance of LDL. And the oxidized LDL stimulates monocyte infiltration, also stimulates smooth muscle cell migration and proliferation, also induces endothelial cell apoptosis, and also induces production of tissue factors by smooth muscle cells. So these are the basic pathophysiological mechanisms by which the high risk cholesterol, that is small, dense, low density lipoprotein and oxidized LDL, increase the risk of atherogenesis and are culprit for atherogenic dyslipidemia. So this is one of the studies in Indian scenario where which shows the prevalence of atherogenic dyslipidemia in India. So over 6,000 patients across 11 cities in India were studied, and it was found that although the Indians have comparatively low level of cholesterol, but they have higher level of LDL, lower level of HDL, and increased level of triglyceride, which is a typical picture of uh, atherogenic dyslipidemia, even if the total cholesterol levels are lower. So, fit heart study, a large population was studied, and similar kind of data was found where the total cholesterol levels were although relatively low, but the LDL level and TG levels were high and HDL levels were lower. This is one of the Indian studies which shows that patients which were studied, around 2,000 patients, they 14% of patients had hypercholesterolemia, 30% of the patients had hypertriglyceridemia, and about 72% had low HDL levels, and 12% had high LDL levels, and 79% of the patients had at least one type of lipid abnormalities. This is very high incidence of dyslipidemia in Indian setup. So a consensus on prevalence of dyslipidemia has been arrived at, and as compared to the Western population, Indians tend to have higher level of triglycerides and lower level of HDL, but the total cholesterol and LDL levels are comparatively lower. So among various lipid markers, the ratio of ApoB to ApoA1 appears to be best indicator of severe risk in Indian patients. How do we assess atherosclerotic cardiovascular disease risk in Indian patients? There are various scoring systems like Framingham and all. So once a patient has come to the OPD and we want to assess what risk he carries over a period of 10 years or 30 years for cardiovascular events, we have to identify patient at very high risk who have high incidence of cardiovascular events in the future. We have to look for various conventional and non-conventional risk factors. We can estimate lifetime risk in all low risk individuals. So this is a table which shows what are the major, moderate and minor risk factors which has to be calculated before a person has to be decided upon whether he needs any kind of pharmacological intervention or whether they will only do good by lifestyle modification or dietary management. As we can see in this slide, that a high risk patient is the one who has three or more major risk factors for ASCVD, or they have one or more other high risk features. So, what are the major atherosclerotic cardiovascular disease risk factors? These are age of more than 45 in male and more than 55 in female, a family history of premature cardiovascular event, current cigarette smoking or tobacco use, high blood pressure, or a lower level of HDL. What is a moderate risk patient? A patient who has two major atherosclerotic cardiovascular disease risk factors is a moderate risk patient. The low risk patient is the one who has 0 to 1 major risk factors. What are other high risk features? These are diabetes with 0 or 1 other major risk factors, CKD stage 3B or 4, history of familial hypercholesterolemia, extreme of single risk factor, coronary calcium score of more than 300, or non uh, increased carotid intima media thickness, or a lipoprotein A level of more than 50 milligram per deciliter. The moderate risk factors are coronary calcium score of from 100 to 300 to 99, a increased level of intima media thickness, a lipoprotein A value of 20 to 49, and a metabolic syndrome. So none of the currently available risk algorithm has been validated in Indian population, but one of the risk factor calculators like Joint British Society's third iteration appears to provide the most accurate risk estimates in Indians. And this can be calculated by going to the website of the scoring system. This is the website. One of the other risk factoring calculating score olden is Framingham risk algorithm, which was endorsed by International Atherosclerotic Society and is more prevalent for the Western population as compared to Indian population. As in Indian population, it uh, falsely calculates lower risk in Indian setups. But to know about it, it takes into consideration only four risk factors. That is cigarette smoking, diabetes, total cholesterol level, and systolic blood pressure. So it is a bit not that good for Indian population as compared to the earlier scoring system. So what are the treatment goals and how what is the recommendation for starting pharmacotherapy in these kind of patients? So in a patient who is at a very high risk with LDL-C level of less, the treatment goal is to keep the LDL-C level of less than 50 milligram per deciliter and non-HDL cholesterol of less than 80 milligram per deciliter. The same goal for a high risk patient becomes less than 70 for LDL and less than 100 for non-HDL cholesterol. For a moderate risk patient, the goals are to keep LDL less than 100 and non-HDL cholesterol less than 130. And for a low risk patient, to keep LDL less than 100 and non-HDL cholesterol of less than 130. This is only after initial adequate non-pharmacological intervention for at least 3 months. And when do we consider starting drug therapy in these kind of patients? When in a very high risk patient, the LDL levels are more than 50 and non-HDL levels are more than 80. In a high risk patient, when the LDL level is more than 70 and non-HDL levels are more than 100. In a moderate risk patient, when the LDL levels are more than 100 and a non-HDL is more than 130. And for a low risk patient, when the LDL is more than 130 and non-HDL cholesterol is more than 160, then this becomes an indication of starting statin therapy. So what are the non-conventional markers for atherosclerotic cardiovascular disease risk? So one of the non-conventional markers which we can use to screen patients who are at high risk of ASCVD are coronary artery calcium score, which can be calculated by a CT scan angiography. Duplex of the carotid arteries, where we can measure the carotid intima media thickness. Aortic pulse wave velocity to measure the stiffness of the arterial wall. The level of C-reactive protein, which is a marker of inflammation. Levels of lipoprotein A, which accentuates the risk of cardiovascular events, and the level of homocysteine, which also is a risk factor for CAD, stroke, peripheral artery disease, aortic atherosclerotic disease, and deep venous thrombosis. So what is the recommendation for low density lipoproteins, cholesterol? So LDL-C should always be the primary target for therapy. Once we start therapy or lifestyle modification, the primary target for therapy remains low LDL. And LDL lowering is essential to achieve the desired reduction in the event rates. In those patients with elevated risk scores, a lower HDL are associated with better outcomes, we know by multiple studies. And this has been proven that even LDL level of less than 50 milligram per deciliter are safe. The recommendation for non-HDL cholesterol. What is non-HDL cholesterol? Non-HDL cholesterol is equal to the total cholesterol minus HDL cholesterol level, and it includes all the other atherogenic lipoproteins in blood, and therefore is more accurate predictor of risk, especially in patients with diabetes, obesity, and other metabolic syndrome, and those who are already on statin therapy. A non-HDL cholesterol is a co-primary target and is also an important target once we start therapy on these patients. Monitoring of non-HDL cholesterol provides simple practical tool for treatment decision relating to lipid lowering therapy, since it does not require fasting level or fasting samples as compared to LDL and triglyceride levels. Non-HDL cholesterol should be kept always within 30 milligram per deciliter range of LDL levels. Statin therapy remains the first line agent for lipid lowering regardless of whether LDL cholesterol is target for therapy or non-HDL cholesterol. Increase in dose of the statin or switching to a more potent statin and intensifying lifestyle measure should be the first step to achieve further non-HDL cholesterol lowering when LDL cholesterol targets have already been achieved. This is very important. And what is the recommendation for triglycerides? Elevated TG is associated with increased risk of ASCVD independent of LDL-C levels. A combination of high triglyceride and low LDL cholesterol imparts even greater risk. High triglyceride is often accompanied by low HDL levels and increased proportion of small dense LDL levels, a patient known as atherogenic dyslipidemia. But the target is to keep triglycerides to less than 150 mg per deciliter and preferably less than 100 mg per deciliter. In patients with elevated TG levels, we should rule out secondary causes of same, and we should intensify lifestyle modification which can reduce triglyceride by as much as more than 50%. Unless triglyceride level is very high, is more than 500, statin should be the drug of choice to start. Only when TG is not sufficiently lowered with above measures, a non-statin drug should be added, like ezetimibe or fenofibrates or PCSK9 inhibitors. Recommendations for HDL-C. Lower HDL is a risk factor for atherosclerotic cardiovascular disease, and it becomes even more important when the level of LDLs is not elevated. Lifestyle modifications play a very important role in raising LDL, HDL, and statin remains mainstay of treatment in patients who have low HDL. Although several other agents were tried earlier, like niacin and all, to increase the level of HDLs, but there was no clinical benefit found from these agents. So, what is the standard of care of dyslipidemia in diabetic patients? So, the latest recommendations by ADA is lifestyle intervention, lifestyle modification, weight reduction, application of Mediterranean or DASH diet, reduction in saturated fats, trans fats, increase in the dietary omega-3 fatty acid intake, increasing physical activity is recommended to reduce the risk of developing atherosclerosis. To intensify the lifestyle therapy and optimize glycemic control, patients with elevated TG and or lower HDL levels should be targeted. In adults who are not taking statins or other lipid lowering agents, it is reasonable to obtain a lipid level at the time of diabetes diagnosis, at an initial medical evaluation, and every 5 years thereafter if he is under the age of 40 years, and or more frequently if indicated, if the levels are abnormal. We should obtain lipid profile at initiation of statin therapy or lipid lowering therapy, and we should follow the levels every 4 to 12 weeks after initiation of a drug or change in the dose of the drug, and annually thereafter, as it may help to monitor the response to therapy and inform medical adherence of the patient. For primary prevention in diabetic patients, what is the recommendation? So, for patients of diabetes who are in the age range of 40 to 75 and who do not have any atherosclerotic cardiovascular disease, use of moderate intensity statin therapy in addition to lifestyle is recommended. For a patient who are younger, less than 40 years old age, it may be reasonable to initiate the statin therapy in addition to lifestyle therapy. In patients with diabetes at higher risk, especially those with multiple atherogenic risk factors, or in the age range of 50 to 70, it is reasonable to use the high intensity statin therapy. For secondary prevention, like the patient who already had a cardiovascular event in the past and also have diabetes, all ages groups patient should be given high dose statin therapy or along with lifestyle therapy. Patients with diabetes and atherosclerotic cardiovascular disease considered to be at very high risk with specific criteria of LDL of more than 70 on maximally tolerated statin therapy should be considered for add-on therapy to reduce the LDL levels. It could be a ezetimibe or a PCSK9 inhibitors. For patients who do not tolerate the intended therapy, maximum tolerated dose of statin dose should be used. in adults with diabetes and age of more than 75 already on statin therapy, it is reasonable to continue statin therapy. But in an adult newly diagnosed patient with diabetes whose age is 75 who was not on statin therapy earlier, it is a physician's discretion to whether to start on the statin therapy or not. So, what is a high dose statin therapy? Any dosage of atorvastatin ranging from 40 to 80 or rosuvastatin ranging from 20 to 40 is considered to be a high dose statin therapy, which is aimed at lowering the LDL cholesterol level by more than 50%. And a moderate intensity statin therapy is in the range of atorvastatin of 20 to 20 milligrams, rosuvastatin of around 5 to 10 milligrams, Simva around 20 to 40, pravastatin of 40 to 80, and lovastatin of 40 milligram, fluvastatin 80 milligram, pitavastatin to 1 to 40. And this is targeted to lower the LDL by 30 to 50, 49%. So, what are the European Society of Cardiology guidelines in patient with cardiovascular diabetes, pre-diabetes, and cardiovascular disease developed in collaboration? So, a very high risk person is a person who has diabetes and established cardiovascular disease, or who has evidence of other target and organ damages like proteinuria or renal impairment in the form of EGFR of less than 30 milliliter ml per minute, or he has three or more major risk factors, or the diabetes is of early onset type 1 diabetes with a duration of 20 years. A high risk patient is a patient who has patient with diabetes duration of less than more than 10 years without target organ damage, plus other additional risk factors like age of more than 65, hypertension, dyslipidemia, smoking, and obesity. A moderate risk patient is a patient with young patient with type 1 diabetes of less than 35 year duration, type 2 diabetes of less than 50-year duration, or with a diabetes duration of less than 10 year without other risk factors. So these are the recommendations for these category of patients. As we can see, with the type 2 diabetes patients with moderate CV risk, the goal is to keep LDL less than 100 milligram per deciliter. In the type 2 diabetes patient with high cardiovascular risk, the target becomes 70, or an LDL-C reduction of more than 50% from the baseline levels. And in patients with type 2 diabetes with very high risk factors and where LDL target is not achieved, we can add another drugs. So primary prevention, how can we do it? It can be done by stopping tobacco, increasing the physical activity, keeping the body mass index by less than 23, a healthy diet, LDL level of less than 100, blood pressure of around 120 millimeters of mercury, and fasting plasma glucose of less than 100 milligram per deciliter. So, what are the benefits of rosuvastatin as compared to other statins in managing atherogenic dyslipidemia in these kind of patients? Various trials have been conducted, like one of the trials is COMET, where rosuvastatin was found to be significantly more effective than atorvastatin in reducing LDL cholesterol levels and also increasing HDL cholesterol levels, as we can see from this chart. The other trial was Stellar, where rosuvastatin was found to show greater efficacy in reducing LDL cholesterol compared with atorvastatin, simvastatin, and pravastatin across dose ranges. Stellar, these are the results of the Stellar trial. Solar trial also found benefit of rosuvastatin 10 milligram dose as compared to the higher dosage of other statins. So, to summarize, atherogenic dyslipidemia is a part of complex cluster of abnormalities of metabolic syndrome with direct correlation with cardiovascular events. Indian patients have increased incidence of atherogenic dyslipidemia and cardiovascular disease as compared to Western population. Assessment of risk is essential before initiation of therapy. Management of dyslipidemia with therapeutic lifestyle changes with statin therapy or statin combination with other drugs reduces the incidence of CV events. Studies like COMETS, Statin, and Solar have successfully established benefit of rosuvastatin to be significantly more efficacious as compared to other statins. Thank you very much. Now I can see some questions on the chat box. Can am I audible to all of you? Hello, hello, hello.
Hello, sir.
Am I audible? Was I
Yes,
audible all
yes,
along the talk? Is my microphone working? Am I audible?
yes, yes, sir. You are audible.
So,
Hello.
the first question I can see is how frequently we should check HSCRP tests. So, as I told you, I showed you in the slide that HSCRP is a corroborative marker, and it is a very generalized marker of inflammation, basically. So, if it is very high, one needs to rule out other causes of inflammation, and if there are no causes found, then that patient becomes high risk for ASCVD. Now, there are no specific therapies to reduce HSCRP. A few we can try lifestyle modification, increase physical activity, and some anti-inflammatory drugs, maybe equaspirin, can be of some help. So it can be monitored once if we are abiding by the therapy or lifestyle modification. Then of course it can be done at every 3 months just to see the trend. If at all there is no other signs of or foci of inflammation in the body to assess the atherosclerotic risk. The other question I can see is when to identify ASCVD. It's a very good question. So, any patient who's been diagnosed with diabetes for the first time or is coming to your OPD with any of one of the risk factors where you think even age, lifestyle, or maybe the family history is very strong and he has he could be at increased risk of CVD diseases. So, at first visit only, we should calculate the risk so that on the follow up every 6 monthly or yearly, if the patient is on the regular follow up, we can follow and we can start the lifestyle modification therapy or whatever drug therapy which is recommended at the earliest to decrease the risk. So at least yearly, I think the risk has to be monitored, calculated. The other question I can see is what should be the targeted triglyceride levels in Indian diabetic dyslipidemia patients. So the answer to this is target should be at best to the less than 100 milligram per deciliter. And when should we initiate statin in such patients? And when should we start combination therapy with fibrates? Okay, the slide was self-explanatory. As I told, once we have calculated the risk of the patient and categorized him as a very high risk, moderate risk, or a low risk patients, according to that, we can choose when to start the therapy. The primary target remains LDL. The secondary target is non HDL cholesterol. Along with that, we also need to control triglyceride levels. So the target of triglyceride level is to keep it less than 100 milligram per deciliter, preferably. Even 150 less than 150 milligram deciliter is also acceptable. So even if by increasing the dosage of statin therapy and by adding other drugs, the target is not achieved, then we have to start more stringent lifestyle modification, carbohydrate dietary restrictions, and other things. The next question I see is what criteria should be considered in Indian diabetic patients between moderate and high intensity therapy? So as I told you, we have to achieve the target of LDL level, non-HDL cholesterol level, and we can follow once we have started the patients on a statin therapy. They can be monitored every 4 to 12 weekly if they are started or there was a dose change, just to see the response, their drug compliance, and how their diet history, their lifestyle modification. So I think the guidelines are very clear about it. Depending upon the risk of the patient, the levels are decided, and the more the risk, the stringent are the levels. So another question is, sir, can we avoid CBG or PSCI by regular dose? Oh, it is a very interesting question. So actually, CABG and PCI are the form of revascularizations which are done in a patient who have critical coronary artery disease and have significant ischemia or angina, which is not controlled by drug, or of course a patient who already has an event like anti-ebol MI or something like that. So of course, trials like Jupiter trial, which was the primary prevention trial for rosuvastatin, has shown that of course these medications, rosuvastatin specifically, if continued in high risk patients, even in low risk patients also, can reduce the amount of atherosclerotic burden, but it also decreases the MACE event rates. But it is not a sure shot therapy. Along with this therapy, you have to have your genetic profile has to be very friendly, your family history has to be good, your lifestyle, your modification. Even then, there are some risk factors which are also unknown till now, which can lead to stress, smoking. So all there are multiple risk factors which needs to be controlled. Only by taking rosuvastatin, one cannot be protected from CVG-PCM. So I think I have done all the questions from the chat box. If at all there are any more questions, I'll be happy to answer. Hello. Hello.
Hello, sir. Hello, sir.
Yes. Yes.
Yes, sir. I think there are no any further questions, sir.
Yeah. What is the question?
So there are no any further questions.
There are no more questions.
No, sir.
Okay. Then shall we? Uh, what should
Hello,
we
sir.
do now? Should we stop?
So shall we end the session, sir?
Pardon?
So shall we end the session? There are
Yeah.
no any
Sure.
further
Yeah.
questions.
Sure. Thank you so much. Thank you so. Sorry for the delay. Sorry for the delay.
On behalf of Lupin, thank you, sir, for your insightful and educative talk. Thank you, sir. I'm ending the session.
Thank
Thank
you
you,
so
sir.
much. Thank you. Bye.